cataract conundrum. Now I would like to call upon Dr. Partha Biswas, who is the president of AIOS, to chair the session. Our president of AIOS, Dr. Partha Biswas, sir, to chair the session. I would like to welcome Dr. Elan, sir, to co-chair the session as the president of BOS. Dr. Namrata Sharma ma'am is not here. I would like to call upon our first speaker, Dr. Muralidhar Krishna, to speak upon cataract surgery beyond the eye, systemic health considerations and intraoperative strategies. Both the talks you
Good morning, everybody. I would like to thank the organizers of BOS, Dr. Elan, for giving me an opportunity for this wonderful presentation. Today I will be speaking about the systemic health conditions which may affect our cataract surgery and what should be our strategy to deal with it. So it's a big ocean, like so many conditions are there, but I will be dealing with only few which are quite relevant to our day practice. One of our nightmare is the cardiac patients. Many things can come because all our patients are old majority. It can be a ischemic heart disease, patients have undergone coronary artery bypass graft, angioplasty, heart failure, arrhythmias, valvular disease, patients with pacemakers, ICDs. So we need to take a proper history first to know what actually the patient is suffering from. Sometimes they are not even aware that they have a heart problem. So mainly the ischemic heart disease if it is a myocardial infarction, at least we have to wait till 6 weeks from the attack to go for a cataract surgery if it is required, that too with a proper cardiologist fitness. Stable angina, we can take it for surgery with all the medications being continued, but unstable angina, don't take it for cataract surgery till it gets stabilized, because there's a problem of intraoperative ischemia. And following stent placement, we have to wait at least for 3 to 6 months before taking them for cataract surgery. And LV dysfunction, again, we need a proper cardiac assessment because these patients are more prone for hypotension and arrhythmia intraoperatively. So luckily we are operating topically, so it reduces majority of the risk factors and it eases our life inside the OT also. And few things which we need to keep a look at is avoid phenylephrine group of drugs without even asking the anesthetist, because it can cause ischemic issues inside. And we need to have a continuous monitoring, ECG, oxygenation, pulse oximeter, everything should be there. And we have to do the surgery as early as possible. We should not prolong it because it causes stress on patient, and we should be ready for any emergencies. That's why I always keep stressing on having an anesthetist in hand. Coming to the heart failure patients, you need better to delay the surgery if the patient is just recovering from decompensated heart failure. Get a proper anesthesia and cardiologist fitness first, and again check for what is the ejection fraction of the patient. If it is less than 40%, don't do it, and take a proper guidance, then only go ahead with the surgery. And the patient who had a pulmonary edema history, whenever we make him lie down, they are always at a risk of developing pulmonary edema again. So always better to check for their oxygenation status throughout the surgery. And then one more thing very importantly is whether the patient is using any pacemakers. Luckily in our ophthalmology surgery, except the monopolar cautery, nothing will interfere with the pacemakers. So make sure that you use a bipolar cautery only. Next, coming to the respiratory conditions, lying flat is very difficult for few patients, especially those patients of COPD, chronic obstructive pulmonary disease, asthma, and those with pulmonary edema. Proper history taking again becomes very important here. Assess the patient preoperatively, whether they will be able to lie down for 15 minutes at least, and you can start systemic steroids in case of COPD to quieten the trachea and airways. And one more important thing is if the patient is a smoker, I would advise him to stop smoking at least 2 weeks prior to the surgery. I know it's difficult. And upper respiratory tract infection, assess personally what is the status, whether the patient is having a very high running nose, which can cause infection if you are not careful enough. Chronic cough, wait till it gets controlled, get a consultation with a pulmonologist. And then one more thing is they can cough or sneeze anytime during surgery. So always follow the rule of moving the hand with the head of the patient. So be anticipatory, patient can cough or sneeze anytime. So you allow your hands to move along with his head so that nothing happens. And always give a supplemental oxygen under the drape so that they don't smother inside. Another issue is neck and spine issues, especially the patients with ankylosing spondylitis, neck fractures, scoliosis, kyphosis. The positioning becomes very difficult. So if the OPD person is different, surgeon is different, surgeon should not get surprised on the day of surgery. Before planning the surgery, make sure you get a preoperative position in the OPD, make a trial how best we can get to a reliable position so that surgeon can operate. It's difficult. It may take 15-20 minutes to find the ideal position. So it can be a Trendelenburg position usually, a reverse Trendelenburg position also. So this is how the Trendelenburg position looks. So, but these types of beds are not there in all the operation theaters. These are specialized beds where the lower end can be elevated. But again, the risk of increased blood flow to the eye causing increased IOP is there in these cases. And in few patients cannot extend their neck. So in this case, we have to reverse this. Reverse Trendelenburg position where the head end goes up. And again, we are operating here outside your comfort zone. So you have to be prepared for it. Sometimes you need to stand and operate. So you have to be prepared for all these conditions. Obesity. Obesity is nowadays commonly seen because of our lifestyle. First thing is the associated comorbidities will be there. It can be a hypertension, it can be a IST, BP. Along with it, the size of the bed also matters. Few patients will not fit into regular OT beds. Sometimes we may need a bigger size bed, and here temporal incision will be very difficult. So better to go with a superior or supratemporal incision to have a good outcome. Another thing is tremors. The patients with Parkinsonism, titubation, make sure that they take the necessary medications for Parkinsonism before you take them for surgery. Sometimes you can tape their head to the OT table also in mild cases. But if it's a severe head tremor, better to operate under GA. And many patients are claustrophobic. Only will come to know when you put the drape. They will try to run away like that position. So you need to assess that first, and in that cases GA is always better, or you can do it under block in mild cases. And always lift the drape of the microscope and tape it to the other structures outside and give oxygen. Another common problem which we have is hearing impairment. Surgeon will not be knowing if he is not seeing the patient in OPD in a high volume surgery. So first make sure the patient is deaf or not. Is it unilateral, or is he using any hearing devices? Many patients may not bring the hearing device to the OT with a fear that it may get soiled with the fluids because it can get short circuited. So we can advise them to use the hearing devices in the opposite side where we are operating, and better to put a water absorbent tegaderm dressing so that it doesn't get spoiled. And you need to talk loudly and know what is that pitch they will understand. And in totally deaf patients, it's better to do it under block. Hypertension is commonly seen nowadays. The upper limit is around 160 millimeter of mercury, and diastolic is around 100. And make sure that they use all the antihypertensive medications prior to the surgery. We can also give preoperative anxiolytics. If still the blood pressure is high, we can give sublingual nifedipine also. And again, in these cases, avoid adrenaline intracamerally. Diabetes, there is always a confusion, like what is the level at which we can operate. Ideally, it should be fasting around 140 milligram per dl and postprandially within 200 and HbA1c of 7.5, less than that. What we need to understand is the duration of diabetes and how well it's controlled. One of my endocrinologist friend used to say, if a patient is having a 400, you will cancel, but if you want to bring it under 200, I will get it immediately, tomorrow only. Will you operate? So it's not like getting only the sugars under control for the day of surgery. It's for throughout. We need that control in action. And we also should know the type of medications they are using, oral, insulin, and better to do these patients early morning to prevent any hypoglycemic attacks. When you come to the oral anti-hypoglycemic medications, better to withhold the morning dose of metformin, sulfonylureas, and SGLT2 inhibitors. DPP4 inhibitors, they can continue. Coming to the insulin, we have to find out which type of insulin they are using. If it is a basal insulin or man-made insulin, they can continue at around 50 to 75% usual dose before surgery. If it is a rapid-acting or pre-mixed insulin, better to withhold the morning dose, and then after that you can continue just to prevent the hypoglycemia. Always get FES, PPBS, HbA1c before surgery, and before making the patient enter the OT, get a GRBS done. Better to go ahead with a topical phaco with minimum energy, because these patients, there is a risk of delayed wound healing. Then the corneal edema may happen if you have not used more energy also, and AC reaction will be slightly high in diabetics. And one more important thing is kidney diseases, end-stage kidney disease, chronic kidney disease, patients who are on dialysis. Get a detailed preoperative renal function test, get a coagulation profile done, get a cardiac clearance, and make sure that if the patient is undergoing dialysis, better to do surgery at least 24 hours post-dialysis to minimize heparin-related bleeding risk, and avoid fluid overload in cases if you are planning any IV.
Murali, please conclude.
And in these patients, it's better to give a topical anesthesia, cautious use of NSAIDs or any antibiotics, and always there should be a coordination between surgeon, nephrologist, and anesthetist. And these are all the things which you can see in a chronic kidney disease patient. It's mainly the propensity to bleed because the anticoagulant is being used. And these are all many hematological conditions which may affect the outcome, especially anemia, which may affect healing, thrombocytopenia, which may affect bleeding risk, leukemia, lymphoma with immunosuppression. Finishing, ma? And patients on blood thinners. So with the warfarin type of drugs, it is better if they continue with it, if you are doing it under topical. And antiplatelet agents, no need to stop it unless you are doing it under block. If you are doing it under block, better to stop these things 5 days prior. And there is something called as bridging, where we use a temporary use of a short-acting anticoagulant. Typically, low molecular weight heparin is started. So here we have to stop heparin first before the surgery, so that INR drops. Then you have to start the enoxaparin drugs. Then you have to hold it 24 hours before surgery. Then we can resume back. Use it only if it's a high-risk case. And lastly, the psychiatric illnesses. If the patient is having schizophrenia.
Murali, we can stop. Time issues, please.
Okay, sir. In summary, better to have an anesthetist standby, and peace of mind of surgery is priceless. Thank you.
Next, call upon Dr. Srinivas Rao to tell us how to keep a cataract patient happy. Happiness is elusive, but I think Dr. Srinivas Rao will throw some light on that.
Request all the speakers to keep to the time, and please wear the headphones so that you can hear what we are talking.
So at the outset, I would like to thank Elankumaran sir and the BOSS organizers. This is my first conference of attending it. Excellent talks everywhere. And I would like to start, before starting this, there was a study done in Chennai by a postgraduate student covering 4 to 5 districts, the phaco surgeons. In that study, she is going to publish it. 1,287 phaco surgeons are there who are performing phaco in those 4 to 5 districts. In that, 800 people perform very well. She is going to publish it. In that 800, 82 of them are having a very great practice. That study, what she has done is, it is not the technique and other things which the 800 people give an equal results. These 87 people do a lot of pre-op, intra-op and post-op talk. Because most of the places where we do pre-op, counseling is done by the counselors or something, they would have promised heaven. So crash them on the pre-op day that this is not so, it can give heaven vision. For example, it can produce halos or it can have other things. And intra-op, assure them whether when they are performing surgery to give Anxit and other tablets, or holding their hands if in a very anxious patient, or after the surgery, when the patient comes out, think of giving a hand and explaining to them, have a coffee, relax yourselves, will great way develop a relationship. Post-operatively also, if there is corneal edema, you start smiling more, so that the patient is with you, the vision is improving or not. And please tell them when it will recover. Please tell them if it is recovering after 15 days or 2 weeks or 3 weeks. Explain to them, which is very essential for the patient, because you know that it will clear. Most of the phacosurgeons know when it will clear. But whereas the patient will convey to the attender. When they convey to the attender, it becomes 100 times. I can't see. The attender becomes very anxious. So explaining all these things will make the patients very happy. The common refractive error worldwide, difficulties post-operatively patients which are not cataract patients are happy, are refractive error, which is greatly reduced with the way IOL masters and IOL power calculations and those things such as greatly reduced. Sometimes we do occur after all these things because of some intraocular lenses can give you surprises. And dysphotopsias, the meta-analysis study shows 62% of the intraocular lenses which is placed can produce positive dysphotopsias, which I will talk about it later. And 32% of the patients worldwide where cataract surgery is performed, where dry eye is there. And this also I will talk later in the coming slides. And photophobia and foreign body sensation, which is commonly seen in postoperative cataract patients, a simple asking them to continue to wear the coolers. Ask them to continue because their retina becomes sensitive for in these patients. They develop some kind of photophobia sensation. This will solve by wearing a simple cooling glass for some more extended time than the normal 30 days period. And foreign body sensation also, which commonly seen, even though plano 6/6, these patients become very unhappy with the foreign body sensation, which you treat accordingly. Dysphotopsias, the meta-analysis study shows 62% positive dysphotopsias are seen, which usually disappears either in 2 days, 15 days, or up to 1 year. And this can be explained to them by the burst and halo effects. Even with the newer trifocal lenses, these are seen. Negative dysphotopsias are seen in 1 to 2% of the patients, where there is a temporal shadow, which you explain to them, over a period of time it disappears. Even though you know that it is things, assuring that patient that these things will disappear, will assure them, either give a multivitamin tablets or a tear substitutes. And IOL master, I will say we have done a study where with the IOL master also, as well as with if you don't have an IOL master, need not worry. Even the immersion technique gives equal result. Almost 463 patients, we compared it with both the things, and the results are equal with almost like the IOL master 700, because even IOL master 7 is expensive, you can't afford. Do an immersion technique or correct your IOL calculation thing. Various formulas are there. You need a separate session to tell that. Usually I follow below 22 something like half a Q and things like that. SRKT between 22 to 26 millimeter, and Barrett 2 also works well. Off late we have tried in around 800 patients Kane formula also. That also looks very good in the IOL calculation, and there are various websites are there. Go and see that. You can apply that online. Free websites are there. You put your formula, cross-check it, cross-check it with 2 formula. In case there is a difference of 1 diopter or something like that, may ensure that you do that, or 1 more optometrist or 2 optometrists calculate these IOL formulas and calculate the intraocular lens power and ensure that the surprises are eliminated. And before intraoperatively, like my chairman Amal Agarwal, when a German fellow came, he asked, which case do you do phaco? So the answer he gave is shave your mush and decide. So even I didn't understand what is shave your mush and decide. Said, no, don't keep an ego. You don't want to do phaco. In case is hard rack, do a simple SAC or an ECC. But explain to the patient that this cannot be done perioperatively, the patients will accept, than doing a phaco in a very, very hard cataract. Or if it is a small pupil and they are not noticed, on the day pre-op day noticed, explained about the iris hooks usage and the visual recovery time. And which case to phaco. Never ever keep an ego and decide not to do phaco in case it is not possible. Other things is, which I explained earlier also, post-operative corneal edema. When you do a hard cataract and things like that, pre-operatively explain to them after 20 days or something, or 15 days or 20 days only, you will start seeing vision. Because they will compare to their colleagues or their contemporaries, brothers and sisters who would have got operated, and they will say that they got the vision in 3 days. So explaining to them that this patient will get vision after 15 to 20 days and assure them you will get 100% of the vision. Burning sensation, all these things, when you are applying a hypersense ointment or a hypersol drops or things, burning, everything will disappear in 15 days. Will reassure them, and the patient will be with you and will not take a second opinion. These are small things which the patient will make happy. 37% of the patient develop dry eyes, which I mentioned earlier. So the dry eyes, the problem is either post-operatively or perioperatively, you cannot treat it. But at least telling these patients pre-operatively, treating them for dry eye, do a dry eye diagnostic test if you have that thing, and explaining to that patient, and then taking up these patients after treating dry eye, will assure that patient, okay, these symptoms are not because of cataract, because patients don't understand. They think this burning sensation or watering because of dryness not get cured. Patient will think they are coming a treatment for that. So explaining to them this patient's dry eye will persist and requires prolonged treatment. And simple things, when to take head bath. I suggest my patients to take head bath in a phaco case after 3rd day, and when to wear eyeliner, when to do facial, when to do dental treatment. All these things will help these patients to retain and help them to get your patients to come back for with their attenders to refer patients to you. And remember, at the 30th day, all your post-op cataract patients, why I say 30th day is very important. 30th day patient will be very happy. At that time, give your card and number. Tell them any problem, contact me. This will help to improve your practice. They will refer to your patients. Why I said 30th days, every 3rd day or 4th day, they start calling you before 30 days. In case patient is having problem, in case you are ready to give a call, please give the number. Certain patients, what we have seen is they are not attended at home. They are left alone, aged patients. So when the attention is given during cataract surgery, they will face problems. So pre-existing mental health also, their neck pain and other things also, they will correlate for the cataract surgery things. Posterior capsular opacity, which patients becomes very, very unhappy, thinking that for lifelong they have vision. Sometimes it happens in 3rd month, sometimes it happens in 1 month, sometimes it happens in 3rd year, 3 years or something like that. Explaining to them, these are very simple polishing, only once in a lifetime it's required, it will not get recurred. Even though you know you are breaking the blood retinal barrier, you can tell them that this will be a simple polishing technique, and by OP procedure you can have a head bath and things like that. Assuring them all these things for treating a simple PCO also will make your patients very happy, and definitely after PCO the patient vision is improved. They think you have given a second vision to that. On the outset, I'd like to thank the organizers for giving me the chance. Thank you.
Thank you, sir, for that wonderful talk. It's important to keep your patients happy in order that you also end up being happy. What happens, sir, when they come with, complaints like there's a foreign body sensation, watering? I mean, these are like generally unspecific, non-specific complaints.
Sir, actually, whenever the post-operative patients are there, we have a standing instruction. I have a reception, floor coordinator and optometrist. These patients, which is post-operatively having a complaint, will taken away in a separate line. It has to be speeded up first thing. Okay. And they should not be allowed to wait there. If they are allowed to wait there, the next patient may cancel your surgery who is sitting for pre-op. So this should be in a separate line, and you should be seeing them fast. And your smile, first of all, should increase more. And receive them holding their hand and things and assuring. You can treat the watering and foreign body sensation. Most of the doctors can treat. But it's your assurance and the mental health telling that these are all simple things. Prolonged drops is required. And this drops, they think we give a tear substitute, we know there is nothing. But explaining to them, this is a natural tears which is kept in a bottle. So because they think something like an antibiotic you are using for a long time, my eyes are spoiled. That's a general trend the patients think. So explaining to them these are natural tears which requires prolonged treatment will help them.
Right, sir. Thank you so much, sir.
Thank you. Thank you, sir.
Next.
I'd like to thank Ilan and the BOS organizing committee for inviting me to speak on this talk. See, in cataract surgery, the main thing what matters is reducing the ultrasound energy used and also the turbulence caused in the antechamber during phacoemulsification. If you are able to reduce the ultrasound energy and also the turbulence caused in the antechamber, which is responsible for release of the inflammatory markers like IL-6, IL-10, MMP9, which are tend to progress the diabetic retinopathy changes, which in turn patients may develop cystoid macular edema and the reduce of endothelial energy, ultrasound energy will cause less chance of endothelial cell loss, and the visual outcome will be better. And also by doing all these things, you will be able to reduce the surgical time, which in turn will help in faster visual recovery. So in Narayan Nethralaya, we did a study of 50 patients in all the category. One is femto laser, other one is regular phacoemulsification, other one is using Manmar chopper. The CD was seen average in about 3.9 in phaco cases, whereas with the Manmar chopper it was around 2.76, so less ultrasound energy used. With the flax it was around 3.41, which was the energy used was more compared to Manmar but less compared to phaco, regular phaco. So minimal CD usage was observed in Manmar chopper group compared to flax and conventional groups. So this is a prospective study, but we are only included, say like as of now, 6 patients with flax and 10 with Manmar chopper and 14 with regular phacoemulsification cataract surgery. And then the patient was subjected for densitometry using pentacam. So day 1, the preoperative total corneal thickness with the flax, it was around 6.25, which was increased to 19.85 on the first post-op day. With the Manmar chopper, it was around 16.7, which was increased to 18.3. Minimal rise in the central corneal thickness. With the regular cataract, it was 22.45, which was increased to 23.15. Marginal increase in the corneal densitometry in the first post-op day. In the day 7, the flax group showed a higher change in the compared to using the regular cataract surgery and Manmar chopper with the central corneal thickness edema. Then how we did was aqueous sampling was taken on the day of surgery. Just before the surgery, the aqueous sample was taken around 0.1 ml, and immediately after the nuclear fragmentation, second aqueous sample was taken. These 2 samples were stored in -18 degree and then subjected to the biomarker kit through ELISA technique. We measured for total protein concentration IL-6, IL-10, IL-7, TNF-alpha, MMP9 and ICAM and VEGF-A. Interestingly, we saw this is the first one is with the phaco, second is with the flax, and third is with the Manmar chopper. The reduction of the IL-6, MMP9, ICAM1, VEGF-A and the total protein concentration were minimal with the use of Manmar chopper compared to the phaco and the flax group. So flax and conventional phaco had higher levels of MMP9, ICAM1 and VEGF-A, which are responsible for the progression of diabetic retinopathy in diabetic patients. And minimal rise of IL-6 and total protein count was seen with using Manmar chopper. And let me come to the surgical video. The left side, what you see is the sustainer, which is a ball tip with inner cutting edge and 2 mm in length. And the right side is the Manmar chopper, which is 2 mm in length and front cutting edge. See, the chopper goes through the sustainer, goes through the side port, hooks onto the opposite equator, and the chopper goes through the main wound, and both the instruments are brought together and it's bisected. So without use of ultrasound energy, we are dividing the nucleus into 4 quadrants. Now you go with the phaco quadrant mode and emulsify the individual quadrants which are pre-sectioned. So minimal use of energy is used to divide the nucleus, or no energy is used. This is another case of white cataract where you go through the side port sustainer, the Manmar chopper to the main wound. See how easily we can bisect the nucleus into 2 equal halves, and rotated 90 degree and then again bisected. then rotating it another 180 degree, and this heminucleus is bisected now. So without use of ultrasound energy, we have now 4 quadrants. So this I call it as manual flax. And this is a very soft cataract. It's a very cheese wiry, very tricky to pre-chop it. But in these cases, you can just make a single fragmentation and then aspirate it out. Other case of grade 2 to grade 3, where you go with the sustainer, hook onto the opposite nucleus, and with the pre-chopper you bisect it, and then bisect it again by rotating 90 degree, rotating it 180 degree, and then fragmenting it. This is another case of small pupil, very difficult to do either pre-chop or even flax or even the regular cataract surgery. Here I use a BX ring. The BX ring is inserted. I go with the chopper. Now I have got an adequate size of pupil. Go hook on to the opposite nucleus with the sustainer, and with the pre-chopper I'll divide the nucleus and rotate it 90 degree and subdivided it into another 2 halves, and it's again rotated to 180 degree and divided into 2 halves. So we have 4 quadrants now. This is a very easy technique, and anyone who are well versed with horizontal chop technique can do this technique of chopping the nucleus without use of ultrasound energy. I thank you all for patient listening. I welcome the panelists and the audience for questions, please.
Thank you, sir, for that wonderful talk. I mean, it's lovely to see that beautiful innovation that makes phacoemulsification so much more easier. Thank you so much, sir. I'd like to invite Dr. Namrata Sharma to the stage. Okay. Ma'am, would you like to give? Okay. Madam will give us the talk on IOCT guided phacoemulsification. It is indeed a pleasure and a privilege to have Dr. Namrata Sharma here.
Till Madam adjusts her slides, I've used Manmar chopper and it's really excellent. Manjunath, if okay, he's here. As good, I've used at least 3 choppers, and I've seen that Manmar chopper is the easiest to use for a beginner.
Dr. Manjunath, congratulations for this innovation, and it's really good. And I could see that you use the BX ring in a smallish pupil. So the B-Octa, I think, also has a promise in these ones, what Dr. Shubhan Bhattacharya has designed for a larger sized pupil expansion. And since the chopper goes right to the periphery, nearly to the equator or near the equator, I mean, visibility would be an important issue while using the chopper.
Better choice compared to BX ring. The B-Octa, I think, is the recent it's come to the market, but it's they recommend it for SICS, but definitely it can be used for phaco, and it gives a better dilatation, and at least pre-chopping will be easier for beginners.
Honor to be standing here, and I would like to thank Bangalore Ophthalmic Society as well as Dr. Ellen Kumaran for inviting me here today. I would be talking to you about intra-op OCT guided phacoemulsification, and there are various steps which helps the intra-op OCT helps in while doing phacoemulsification. So when you make the incision, you actually know the level at which the incision is being made, whether it is multiplanar or biplanar or a side port which is being made. And when you have wound side DMDs which are present, which may be present at this site, then it again helps you to identify that. So for instance, in this, it's a multiplanar incision, and you can see it because this view comes simultaneously with your microscope view. So the surgeon can actually see what is also happening in the third dimension through the intra-op OCT microscope. this is integrated into the operating microscope. And when you give a neck, then you have to actually focus on the lens like this, and then you can see the capsulorhexis which is being initiated. And this may not be of help, especially when you are actually doing normal cases. But when there's haze and if you lose the edge of the rhexis there, then one can pick it up. And also, if you have a running away rhexis, then again you can see the flap motility sign. Then when you do hydro maneuvers such as this, like hydrodissection, then you can actually, then you can actually see the wave of the hydrodissection fluid which is going in between the posterior capsule and the cortex, and a clear area of separation if it is a posterior subcapsular cataract and if it is not a posterior polar cataract. And if there's a defect present in the posterior polar cataract, even that can be seen. Then as hydrodelineation is done, the maceration of the cortical matter can be seen. And then when you're making the crater, you can actually see the depth of the crater over here. So you exactly know how deep you are, and this is good for the beginners. Then this is the epinuclear plate which is left, and as you notice how the cortical plate and the epinucleus moves up. But as the viscoelastic is pushed into the capsular bag, then the whole thing will be pushed at the back. And whenever the posterior capsule bulge comes up, that also can be seen, and when it moves down, like in this case, then that also can be made out. Then even while IOL insertion, you can see that the wound is open and the IOL is being inserted, nothing much to it because that can be also otherwise seen. But what is important is when you have viscoelastic in between the intraocular lens and the capsular bag, then you can see the cushion of the viscoelastic by the gap which is present between the lens and between the posterior capsule. And as we aspirate this with the help of the irrigation aspiration probe, you'll see that this gap would decrease, and this wrinkly posterior capsule will also tighten up as the wounds are hydrated. So this gap has decreased, which means that the viscoelastic is out between the PC and the IOL. And as you do the wound hydration, one can also see the spindle of the hydration that is present here. If there are wound side DMDs, one can see here. Then one can also see whether the anterior part of the wound is opposed or the posterior is opposed or both are opposed, which can be very clearly gauged in the intraop OCT microscope. So notice here that there is a little bit of anterior gape which is present, so you would have to inject some more fluid so that it completely closes. And so these finer nuances can be made out by the intraop OCT microscope. Now there's a port side DMD which is present, which can be seen here. There's a small Descemet's membrane detachment which will not be seen here because of the fact that it is hydrated. But when it is there, then one can put the air bubble at the end of surgery. Now this is clear-cut posterior subcapsular cataract, and notice that the PC is quite intact, and so if you do hydro dissection here, there will not be any problem. But if it is a posterior polar cataract such as this, then one has to look for any deficiency present in the PC or not, and then one can predict whether a defect would occur during the surgery or not. Then in cases of white cataract, again you can see that there are fluid spaces, black fluid spaces present in between. So if you give a nick in the posterior capsule, the fluid will not come out because the intralenticular pressure is not very high. And one can then again the everted part of the flap or the anterior capsule can be seen here as one completes this capsulorhexis. Subsequently, if there is a white cataract in which there are no black areas present, which means for sure that when you give a nick in the anterior capsule, the fluid will come out. And this blob of fluid can also be seen here, and this helps you to plan your surgery on the table itself. This is a case of capsular distension syndrome where phimotic ring is present. So you remove the phimotic ring and notice the gap between the PC and the lens, and as this phimotic ring is removed and viscoelastic is aspirated out, notice how now the PC is sitting bang on the posterior capsule and there is no gap which is present, and the capsular distension syndrome is now relieved. So it does help to fine-tune your surgery, and we did publish the correlation between the gap between the IOL and the PC using intraop OCT microscope, and this varies with the type of the lens and the way and also the whether it is a single piece or a 3-piece lens. Now this is a case of Descemet's membrane detachment post cataract surgery, and you put the air bubble, but it looks it's stuck, but it is not stuck. There is still some gap which is present, so you have to put that pressure for a good 8 to 10 minutes, give external massage, so that actually now this area tends to become clearer on the anterior side, the cornea, and you can see that it is quite stuck, but moves a little bit as your needle comes out. So the end point would be that there is no gap present between the Descemet's membrane and the overlying stroma. And this is the last video just to show how it helps. This was a case, in fact, simulated, which was referred to us after the whole disc came out. The surgeon put the disc back and sent the case to us 2 hours later. And 2 hours later, this is the case that we had, and we didn't know which side was up. Whole disc was there inside, but which side was up? So you have to look at the biceps curl upwards configuration. When you get that biceps curl upward configuration, such as this, now the biceps curl is upwards. Now you know that the endothelium is actually looking down. So it helps you to know which side is up and which side is down, especially in complex cases. And now it is quite stuck to the back of the cornea. The patient's own Descemet's membrane, so we call it autodemic. So this was our review article published in Survey of Ophthalmology on IOCT guided anterior segment surgeries. And so to conclude, intraop OCT helps to refine the steps, it helps to see the unseen, and also helps to understand the intraoperative dynamics during phacoemulsification. And Dr. Partha Bishwas is sitting here, and on behalf of the AIOS and the President and the entire Governing Council, I would like to invite you to 2 conferences. September last week, Amritsar Midterm Conference, and Jaipur March 12th to 15th, which is our annual conference. So please be there. Thank you for your attention, and thank you so much again, Ellen, for having me.
Thank you, ma'am. Despite your busy schedule, you came here. Thanks a lot for that. Ma'am, definitely IOCT exceptionally good, but I mean, as a practitioner, most of us here are practitioners. That's the reason.
I know.
What would be your?
So I think as of now the cost is quite prohibitive, but I know that Indian companies are coming up with this, and very soon, just like for everything, the cost is too much in the beginning. Very soon the cost would decrease down, and already I think Appaswamy is already working on it, and I know of a couple of other companies, multinational, but they are also coming with the reduced prices.
Thank you, ma'am.
So the bottom line is that very soon all your diagnostics are going to march into your operation theatres, whether it is OCT or it is pentacam or a video keratography, so that then and there you can rectify the problems that are there.
Thank you, ma'am.
In select cases, it has a lot of promise, especially in the complicated cases where you showed a cornea which is a diseased cornea, the visibility is low, and especially in Descemet's disease, especially descemetocele, Descemet detachments, instead of injecting the gas or the air blindfolded, so it's best to go in for the ISOCT if it is possible in the city, and do it under proper visualization, because of the very thin amount of fluid which can actually be the inhibitor to a proper attachment.
Thank you.
Thank you very much, ma'am. I'd now like to call upon Dr. Nivyan Marivanan to speak on second to none secondary intraocular lenses.
Of a flanged IOL, and the third the CMT flex. So as you all know, Wurst was the one who actually got the idea from the lobster claw for designing the iris claw lenses. So they're relatively simple design. It's a one piece, one material, and it is basically fixation mechanism of how the iris tissue gets enclaved in it. There are only two key things that you have to know. If you see the forceps, you always need a broad tipped forceps because you have to have a good hold of the lens when you're going to enclave the tissue. The other forceps, sometimes the lens slips, that is when you keep doing it multiple times. And sometimes it's good to check because sometimes this area is fused and sometimes you go, it's a blind procedure, you go under the iris. So when that area is fused and you keep trying to put, you can cause damage to the iris. So just check whether that gap is there and not fused, and then before you start the procedure. So let us just go through a couple of case scenarios. So this was an old aphakic patient. So why I said old is because the pupil becomes rigid and the iris atrophy is there. Because it's a single rigid lens, you need to have a nice sclerocorneal tunnel. For any secondary IOL, the golden rule will be to have a good vitrectomy. So even though, if you can see here, you have round pupils and then there's nothing in antechamber, I always prefer to stain the antechamber with triamcinolone. So I usually stain it and then wash it away. So what you can see here, those fibers, those are the actual vitreous strands that are there, which was not initially seen. So you can use a 23 gauge or a 20 gauge cutter through the side port. Make sure you do a good anterior vitrectomy. So this is very key in helping for post-operative reducing any VMT of inflammation. And this some amount of tricot that you use is also helpful in reducing post-op CME. So it's got dual advantage. So once it is cleared, make sure you fill it with viscoelastics. So the key here is always that 180 degrees where you make the side ports where you're going to clip. As I said, a good grasp. The only trick I follow is my second instrument is already there where I'm going to clip, and the best area is the mid periphery. It is only when you go closer to the iris you get the peaking of the pupils, and if you're towards the root you can damage it and cause bleeding. So mid periphery of the iris is an ideal place, and you'll just see once you clip it you'll see a small dimple. So that much is enough. You don't have to go through and through or damage iris. So again you can see my instrument is already there in the mid periphery where I'm going to clip, and then so just going to show you the same thing in a different way. Just to slow it down again, you can see the other trick is the right hand has to always come up and the left hand is pushing down. So sometimes initial days when we are trying to push it down, automatically your right hand also tends to go down. So that is why we don't get the clip. So the right hand pushes up while the left hand goes down. Same thing for the other side, just in slow motion. Once you have a firm grip, so now the left hand is going to push the lens up. So even when you push the lens up, you can see that the iris lifting up. So it makes it easier for you when you actually push down your second instrument, which is a blunt instrument, and partial enclavation of the iris tissue in that. So when you do this, you do get round pupils and also good dilatations. Yes, complications are there for any secondary IOL procedures. You can get irregular pupils, iris bleedings, iris tear, non-clipping or breakage of the haptics. So we have done a large series of comparing iris claw lenses with SF IOL, and we found really good results. So in secondary IOLs, I would always say it is like depends on the case and depends on what technique you are good with and what is applicable for the patient. I think you should match all the three to get good results. It's not like one type of secondary IOL is the best or better than the other. Moving on to the next interesting technique, the flanged IOL. This is like a modification. This is again for people who use a lot of SNC and rigid lenses. So here what we do is the 0-180 degree is very key in marking. We use a 7-0 Prolene suture with a straight needle. So basically here we're just bisecting the eye into two. So the other side through the railroad technique, just feeding it into the 30 gauge needle. You see the suture is brought out. So once it is done, I'm just going to bring the central loop outside. So what I've actually done is once you bring that loop outside, I just cut it. So you have both the ends out in one single pass, isn't it? So in these rigid lenses, you have that hole that you see. So I'm going to pass the sutures through the hole. So usually one side we come from below upwards and the other side we come from above downwards. This is to have some torsional stability of the lens. So once it is passed into that loop, we are using the heat cautery to make the flange. So the only trick here is make sure that the flange is slightly big enough, and also you pull and see so that it doesn't slip, because I found out that different types of these rigid lenses, the diameter of those holes changes, isn't it? So always just check it outside so it doesn't slip. So once you go inside, you pull both ends just to make sure that your centration is good. So once your centration is good, the second key is you hold one place and then flange the other end. So this is not, the lens is not dislocated. It is once you hold, you fix the area and then make sure your flange goes all up to the conjunctiva, isn't it? So once one side is done, then you can do the other side. And these flanges are pushed under the subconjunctival space. As you can see here, very well said. It's an alternate technique, and it's an easy technique when you have these rigid lenses and you have these complications on table after doing SICS. So these are some of the post-operative pictures. As you can see, here also you have good dilatation of the pupil. So moving on to the final technique, the CM T-flex IOL. So I do not have any financial interest. So this idea came up to me because we have different types of secondary IOLs, but most of them were modifications of the existing lens that you do different techniques like either externalizing it or gluing it or cauterizing it. So that is when the idea came, why not have a lens that is a single piece hydrophilic lens with these specialized T-shaped haptics that can be used for these aphakic patients. So I'll just show you one of the case. This was an interesting case which had an opacified IOL. So I'm not going to show you the entire removal of the opacified IOL because it was coming with the IOL bag complex. For any secondary IOL, again as I said, 0-180 degree is very important. So once we mark the 0-180 degree, so using the Ashwin's glued IOL marker, we make 2 by 2.5 partial thickness scleral flaps. So I usually like to do them with a crescent. So I do it and then cut it outwards. So that way I find it easier to get these flaps and then just slice it outside like that. So you get nice partial thickness scleral flaps on both sides. So as I said, this is a single piece lens as you can see here, and it's also got an angulation. So this angulation is given so that it sits like a hammock behind the iris and there is no rubbing of the iris, so this there's no pigment dispersion or inflammation that is there. So the first trick is when I load it, you can load it in any normal foldable cartridge. So the first thing is I make sure that the T haptic is gone inside so that when you inject the cartridge, the T comes out first, so it's easy to hold. The other trick here is we make the sclerostomies perpendicular to the limbus. So initially even I was making it parallel. So nowadays we make it perpendicular to the limbus. So when the cut is perpendicular, the T sits at 90 degrees. So it just means that there is lesser chance when you're pulling the other side of this slipping back inside. So here we also have two specially designed forceps, the Pranav T-Flex. It's just that basically it should have a blunt, this thing should not have a sharp edge like any VR forceps. So once the T comes, just hold it. Okay, and now I'm not pulling it out. The third trick is to inject the remaining of the lens. Again, it is a single lens, so when you pull out, it can detach. So now I'm just injecting the IOL, making it free from the cartridge and leaving the trailing haptic, and then pull it out slowly. So now the lens is free from the cartridge. So you can see the pop of the T that comes out. You have the pop sign, and then you can see how it sits at 90 degrees when you have a sclerostomy that is made perpendicular to the limbus. For the other side, we use the handshake technique. As you can see, we have another forceps which has got crisscross margin so that there is no dent, and this one particular thing I call the head-on position. Why this is important is I have heard many people holding the neck, then you have a bulkier portion when you pull out to the 23 gauge sclerostomy. In this method, when you're pulling it to the sclerostomy, you see those edges bend inwards. So basically you have a lesser diameter of the lens that comes out through the 23 gauge. So it makes it easier and smoother when you pull out the lens, isn't it? So there will always be a tug at the sclerostomy there. So just wait for it. Don't be in a hurry to pull it. And then you can see it will slowly, smoothly slide in. So because of the 0-180 degree, just 30 seconds. So you can see the centration and this thing all depends on how you mark the 0-180. And because of the thickness of those haptics, you don't have to glue or suture it. Initially we were doing glue, then suturing. Nowadays I just cauterize the conjunctiva. So basically there is no leakage. When you use 3-piece lenses, they are thin haptics. So that is why you will have to do something. But here, because it fits into the sclerostomy, so you can just do. We have almost a 5-year study result that has been published now. We've done UBM images and OCTs through the conjunctiva to see the long-term erosions or how these material sits under the flap. So yes, a lot of publication that has come, and so it's relatively easy to use for both anterior. The way I showed this case is we used an AC trocar maintainer. So basically for any secondary IOL procedures, if you see, make sure that the eye doesn't go into hypotony because that makes it difficult for the people to do the surgery. So this lens has come a long way, and we also have a kit which comes with all the instruments here, and these are some of the publications. So once again, thanks BOS and Ilankumaran sir and Pallavi ma'am for this wonderful opportunity. Thank you.
Thank you, Dr. Nivian. Thank you, Dr. Nivian. I request Nagesh to set up his slides. Dr. Nivian, out of all these techniques, do you have a tip and trick in a less than a minute? Which one do you choose where? Just one sentence.
Sir, as I said, it is actually only case dependent. So if it's going to happen on table on a this thing when you have a whole bag removal in SICS, definitely even till today, even though I know all the techniques, claw is still the best. I think Partha sir will also agree. If you know how to do a good claw, good anti-vitrectomy. So make sure there's no vitreous, and then you place a claw. That is the ideal thing. But when it's a planned procedure, when there is a secondary option, you're waiting for 2 weeks, and then any of the second, that's what I said. One, your technical skills and which one you are comfortable with, because the M&A technique or the modified M&A technique, and depending on the iris also, because if the iris is not there or any iridiolysis, then the iris claw goes out of position. But nowadays it's only CM T-flex, so I wish everybody could try the T-flex and then give their feedbacks. The thing is, why I showed with the trocar is even anterior segment surgeons using the AC maintainer can do it. So that's the only take home.
Thank you.
Thank you.
Yeah, Nivian, it's a wonderful innovation that you have come up with, and it stood the test of time. I think all of us in the planned procedure should try the T-flex. Why? Because the integrity of the globe and the hypertonicity is not there. So the dissection and placing in the lens as well as taking it out, the haptics being taken out, is much easier procedure. Whereas if you have a hypertonous globe, everything becomes very difficult.
Correct. Thank you, sir.
On the outset, I would like to thank the entire BOS team and Dr. Ilan sir for this opportunity.
Closer to the mic, closer to the mic.
I have no financial interest to disclose. So when we think about hard cataracts, so we think about grade 5 nuclear sclerosis and above, like this cataract or rubra evanescent cataract or plaque cataracts. So how are they different from your day-to-day cataracts? So they have this dense hard nucleus and with little to no cortical matter at all. And the suprahard central core, or the endonucleus we call it, and the leathery posterior plate, which is very difficult to cleave. So when we come to the protocols in dealing with these hard cataracts, I would like to divide these protocols into preoperative protocols, intraoperative and postoperative protocols. In preoperative protocols, I would like to take a good detailed history, concentrating upon the diabetes control, where the diabetes cataract tend to be more leathery, and whether there is any treatment they are taking for benign prostatic hypertrophy. And I would like to look at the dilatation, how much the dilatation is there, and if there is any iridodonesis or phacodonesis especially, because this is a very large weight of the cataract is there in the patient's eye for long duration, so zonules tend to become weaker and lax. And specular microscopy is a very important investigation I would like to do preoperatively, and also assess whether patient is cooperative for your usual topical anesthesia or not, and if not, always try to give a peribulbar or parabulbar block. So in intraoperative protocol, I would always like to, even though if the dilatation is adequate, I would like to put a mydriatic, intracameral mydriatic, this one, and also stain the capsule always. And even the intracameral anesthetic like a lidocaine is also very important, because these surgeries tend to be little prolonged, more than 20 minutes, and just a topical drops may not be suffice to give a painless surgery in these patients. And always stain the capsule, not just that there is little to no posterior glow in these cataracts, but these stained capsule always acts as a beacon of hope when the surgery goes southwards. And always use a dispersive OVD like a Viscoat or Hylocoat, and this dispersive OVD should always be injected in a bare eye where you have not used any other OVD before, so that they go and coat the endothelium perfectly. And the rexis, I would like to have a little larger rexis than usual, 5 to 5.5 millimeter, which makes the maneuvering easier, and also the posterior capsule is very thin in these during the hydrodissection. If there is a increase in the pressure inside the capsular bag, this will, the large posterior large rexis will give us some room for the upward movement of the lens. So one technique I would like to follow in these cases is crater divide and conquer, where I make a crater in the center where I do all the phacoemulsification away from the endothelium and remove the most of the endonucleus, which is very hard, and then try to divide this one peripheral portion into multiple pieces. Before that, I always make a small piece and I remove it first to make room for the maneuvering inside, so that I am not putting any pressure on the zonules in these cases. So first I remove this central one small piece, then the division will be much easier and you have more space for maneuvering these pieces while dividing. Even though there is leathery posterior this one plate, you can separate them little wider so that the posterior plate is also getting separated. And always where you do the maximum phacoemulsification is very important. In the iris plane is well, this one, don't go close to the endothelium. There are almost 11-12 techniques which have been discussed in dealing with nuclear chopping techniques in hard cataracts. You can follow any one of these and master one technique which suits you best, and that will give you consistent results. Another this one novel instrument is my MI loop from Zeiss, Carl Zeiss Meditech, where you pass a stainless steel string into the capsule, rotate it to the center, and then withdraw it. That the steel ring will cut through the nucleus. So as you see, it has cut through and through. If you want, you can rotate it 90 degrees and again make another pass, so that you have 4 pieces. This was my first case, so I just stopped at 2 pieces. And another this one technique you can follow is decrease and conquer, where you do multiple chops after making a small crater, and you divide the peripheral plate into multiple pieces, and the central endonucleus gets separated from the rest of the nuclear plate, and you remove that endonucleus, then the rest of the this one will be very easy. See, I have divided into, see the endonucleus, that has gotten separated now. So once I remove that endonucleus, now there is hardly any nucleus left. Or you can just do a direct vertical chop in such cases. Just go deep and have a long this one chopper and just cut it. So post-operative protocols are also very important in these. If there is lot of iris handling, always give intravenous dexamethasone soon after the surgery to reduce the inflammation. Never hesitate to give hypertonic saline in these patients, and step up topical steroids based on the inflammation, and also consider topical rho kinase inhibitors like ripasudil if the corneal edema persists for more than 1 week. So take home message: having a fixed routine prior, during and after surgery helps in avoiding unnecessary complications. Practice one technique of nuclear extraction and excel in it for consistent results. Post-operative care is as important as a good surgery. Thank you.
Thank you, Dr. Nagesh. That was a wonderful talk and a wonderful set of videos as well. In the my loop, when you are inserting the my loop, how do you prevent it from, injuring the PC?
That's what, it's a very smooth instrument, and it already has a shape of the nucleus. So when you are passing, you will pass it most adequately circumferential to the nucleus, and it will not it is, and also while removing also it's a centripetal force, so there is very less this one pressure on the zonules as well, so the cut is very smooth.
Thank you.
Nagesh, that was a very good collection of videos. What is your advice to the beginners how to start it? Yes, you spoke about the techniques. You also spoke about the pre-phaco maneuvers, what you are supposed to do. If a beginner has to do phacoemulsification in these hard cataracts, what is your suggestion?
So one technique of dealing with nucleus I would suggest is crater, divide and conquer. That's why I showed that first, this one. The crater part, how much crater one should make to before chopping the pieces, that can be progressively increased depending on the patient's, the surgeon's expertise. So for beginners, they can have a more peripheral this one nuclear plate left, so that they can impale during the chopping this one. For advanced surgeons, you can remove most of the nuclear plate with the torsional phaco away from the endothelium in the beginning itself, and the divided pieces are very less, very thin, and you can bring it slightly above to the iris plane and then deal with it away from the endothelium again.
So 2 points. One is to debulk the nucleus. Either you can do it by your crater divide and conquer or direct divide and conquer. The divide and conquer, what we don't remember, we feel it's 4 pieces. No, it's actually around 5 to 6 pieces because you're completely reducing, so easier to chop. Thank you, Dr. Nagesh.
Thank you, sir.
The next presenter is the president. He's going to talk to us later about it, but for the time being, he'll be talking to us about difficult situations in flax.
Thank you very much, Ilan, for that very, very generous introduction. And thank you very much, Bangalore Ophthalmological Society, for giving me this opportunity to be here in this silent hall where I would love to boom and say so many things, but you have made me silent. Yet, silence speaks most, and with silence comes a lot of difficulties that we can share with each other and have important take-homes for these situations where we speak about the highest end of technology that is possibly affordable or not affordable. So flax at times is not affordable to our general cataract patients. However, flax is important and difficult situations can arise in flax. Thank you very much. So let's look at flax. Now, the advantages, of course, it gives a very, very standardized corneal incision, and that's something that we all understand and estimate. However, at times, the side port incisions might not open for different reasons, especially if there's a thick arcus or the side port has gone a little beyond the limbus and is nearly in the plane of the sclera, and the conjunctiva might have been intercepted. The lens nucleus fragmentation in very hard cataracts is a very, very important aspect, whereby we reduce the amount of the phaco energy being dissipated into the eye, and the CDE comes down dramatically in these very hard cataracts, and that's one of the best advantages of flax. The astigmatism correction, with its limitation of about 1 diopter to 1.25 diopters, is something that is again repeatable and can be affordable in flax. The OCT gives extreme precision, and in the hypermature cataracts where you can see also the pockets of fluids and you can preempt whether this particular hypermature cataract is going to have a runaway rhexis or not. And of course, because all the incisions are as well modulated as possible, so the recovery is faster. So let's plan for flax. It has to be an engagement, and it has to be customized to the needs of the patient, and it has to be something that we need to give the patient a good treatment. But why flax? So let's look at this very hard cataract, and I thank my previous speaker for giving so many other options. This also becomes one option. You can see it's a grade 4-5 cataract with a very, very thick nucleus, and the capsule can be removed very well, and this can just go on. But let us also remember that in these very hard cataracts, it's not only the cataractous hardness that's important, but also the fragility of the zonules, as well as the desmids that is going to bear the brunt of the dissipation of the energy within the anterior chamber. And thereby, protection of both the zonules is important, as well as the protection of the desmids membrane is important. So with this, the coverage of the dispersive viscoelastic to cover up and to protect the endothelium becomes a very, very important task. So we go ahead with the sextant removal, and not only 6 pieces, 6 sextants can be carved out, but even larger number of pies can be carved out, as well as softening of these pies can also be done if you wish to do it, and that the software gives you the ability to do such things. So you can see that though it's a very hard cataract, and you can see that there's hydration also of the edges of the main port. It's not a cornea burn, but it is hydration that is occurring, and it's important that you be very, very aware of the amount of energy as well as the zonules that are there in place. So this becomes important in these hard cataract management, and then you have a very good corneal endothelium post-operatively. This is done under hydroimplantation, and the lens settles quite well. Now let's look at the rhexis. The rhexis is one of the most important aspects in flax. But can a rhexis run out in flax? Yes, studies have shown in the previous software programs in the flax, the rhexis was not as tough. But it has changed, and the rhexis is nearly as tough as the manual rhexis that we do in our phacoemulsification techniques. But here, let us see that there is a possibility that the rhexis can run out, and you can see that we are doing phacoemulsification, and this is not a difficult cataract. Everything is going on quite well, and things are going well. However, when I see very clearly there is a run out of the rhexis in that part, and we put in viscoelastic to help reduce the amount of stress on the run out rhexis, so that it does not go on to the equator and does not become a full rip of the posterior capsule. So very, very gently under viscoelastic cover, the intraocular lens can be placed inside the bag, and things can be managed quite well. Let's look at another situation of a subluxated cataract. You can see that the luxation is so high that there's hardly much of space in the anterior chamber. The whole cataract is going up, and there is a very small anterior chamber that there is. So here we do not do the side ports, because as you can see that my side port instrument is actually hitting the anterior capsule, but the rhexis has already been made, so I'm not so worried about it. I put in dispersive viscoelastic, and in these cases it deepens the anterior chamber to an extent, but not widely enough. And then the importance of very, very minimal and gentle hydrodissection, because we do not want more of luxation into the anterior chamber. And once this is done, the cataract is now ready for removal. And once we remove it, we are able to place the CTR inside the capsular bag. So once the CTR goes in, the stability of the bag that it affords is much, and thereby once the CTR is there nicely in place, you would know that whether you need to give any additional devices or not. If no additional devices are required, the rest of the part is pretty simple, and you can simply take off the cortical matter, the nucleus, which is not very hard, and this usually solves the problem. Now, if this particular capsular bag was not stable, I would have placed additional devices such as the AMED segment, but here it is not required, and the intraocular lens, once placed inside the bag, can stay quite stable. So we have placed a trifocal intraocular lens inside this bag. It is very stable, and this is how we close this particular case. Now let's look at this posterior polar cataract, in which there is a deficit, a very strong deficit in the posterior pole, and you can see. So here the nucleus that we are going to carve out is taken into that consideration, and the nucleus covering is definitely much above where we would want, and so that we can actually see that the posterior polar part is not negotiated. Then in such a cases, the advantage of flax is that we can do a very gentle hydro delamination, and the fluid will never go into the posterior pole and will actually get dissipated in between the nucleus. So removal of this particular type of cataract becomes very easy. The chances of the posterior capsule giving way is much less, and we place in the intraocular lens inside the bag. So this is another situation wherein the flax becomes a great advantage in a PPC situation, whereas where you can actually protect the PPC by the cushion of the cortical matter. Let's look at this particular video, and this is a video in which it was a very hard, again nearly a grade 4-5 cataract, and we removed the cataract, the nucleus, but what we had is zonular dialysis. So with the zonular dialysis, we are placing the CTR from the side port and negotiating it so that the capsular bag becomes as center as possible. Now we also will have the possibility of having the vitreous in the anterior chamber, and it's important that we place in the CTR as well as the bag, as well as the intraocular lens inside the bag. Once that is done, we need to see how much of vitreous is there, and the tricot usage is done, a vitrectomy is done, and it's important that you do a good and correct vitrectomy just to see that the vitreous has been removed properly. Now here, of course, I would like to tell you that look at this, the vitrectomy cutter is not working, and for all anterior segment surgeons, the OT assistants will be very tardy to give in a new cutter. So it's important not to pull on this vitreous and to exchange the cutter for a proper cutter, and here we have a proper cutter in place, and under fluid it needs to be taken off. The vitreous strand that there is definitely needs to be taken off, because if that is not taken off, then you're going to have a pull on the vitreous base, and that might make things very, very difficult. Let's look at the next case, and this is a case in which it was a very high myopia in which we had an ICL implant, and nearly after 15 years the patient developed this cataract. So the cataract developing, I just want to show you this. Now when the cataract develops, it's important to understand that there are two planes that the OCT is going to determine. So the first plane that it takes as an offset is the plane where the ICL is already there. It is the plane of the anterior part of the ICL, but that's not the plane that has to be taken in the OCT where the cataract is in a lower plane. So you have to manually reset the anterior plane, and that has to be done so that the anterior capsulotomy that you're going to make is proper and in that proper plane. So we will manually decide and take it into that proper plane, and that's important that you understand between a normal case and a patient. This is where the right plane is, and the case where an ICL is there. So with the ICL, the laser goes in through the ICL perfectly, and there's not much to do. Of course, the ICL has to be removed, and this is how we remove the ICL in one go, hand over hand technique, and the ICL is out. After that, of course, it's not so difficult. The capsule comes out, and the rest of the whole process is quite easy. And of course, because it was a very high myopia of minus 18 with a very small cylinder, we placed in a multi-piece lens, which was the only possible lens for this case. And you can see this was done very, very long ago. It was a V4 lens of the ICL, and we had done a PI in this ICL when we had done it many years ago. Now let's look at another situation, and that's a skipped capsulotomy. Now I just want to show you that this was my mistake. I had pressed on the pedal, and inadvertently I had taken off the pedal and repressed it. So what happened is the capsulotomy aspect did not start and was skipped. So when it becomes, and then because I pressed for the second time, the nucleus management and everything else was done. So here I'm in a situation where I have to do a manual capsulotomy, and I'm all the time fearing whether actually the bubbles that have been produced during the sextant carving of the nucleus can rupture the posterior capsule or do damage to any part of the zonule. So here I do a manual rhexis in this situation where already the nucleus fragmentation has been done by the femtosecond laser. But I think I'm going to be lucky here because the capsule has not given way, and it definitely depends upon the capsular strength, and so the rest of the surgery can proceed quite easily and exactly as we have planned it. So we come to the last part of the last video that I'm going to show you, and this is one of microspherophakia. In microspherophakia, again, the importance of, you can see that it's a full spherical lens that we have here, and that's important. Here we are going to do only the capsular rhexis because that's the toughest in microspherophakia surgery. If a good capsular rhexis is done, the rest part is very easy and does not require much of an intervention. So we do this full capsular rhexis, and look at this. Now I have, then we carve out the Hoffman's pocket to do fixation of the bag with the Ahmed segment, which we are going to put at a later stage. Now, as you can see that it is a postage stamp cut, and you can see the zonules which are so deficient, and the postage stamp cut of the rhexis comes out. Of course, it is not going to be a very, very strong rhexis, and we have to keep that in mind. It's a very small capsular bag, and thereby we use not the capsular hooks, but the iris hooks to hold this bag in place, because the flanges of the capsular hooks are much too large and will not be able to hold this. So we put a single piece lens inside the bag, and once the single piece lens is placed inside the bag, the single piece lens goes in very, very well. But this bag has to be fixed, because otherwise it will move off and we will have difficulty at a later stage. I'll just take 30 more seconds. So we flange and we have the Ahmed segments in place, and once the Ahmed segments are in place, the capsular bag comes to a very good centration position, and with the tying and the Hoffman's pockets, which is quite elegant. And so we have a central lens, but you can see that the flanges of the Ahmed segments are very much there. But usually these patients benefit hugely from the intraocular lens and from the surgery. Thank you very much.
Thank you, sir, for that excellent collection of videos. I think many of us have not seen those also. Sir, we'll have the discussions later, a little bit short of time.
Yes.
Thank you, sir. Now I invite Dr. Ellen Kumaran to give his talk on active fluidics with active sentry, advanced trifocal IOL, Panoptic Pro, as well as there are two talks in the lineup, management of dry eye in cataract surgery. Or rather the other way around, management of cataract surgery in dry eye.
Thank you, Dr. Soumya and Dr. Nagesh. The first I'll go with the trade talk. Active sentry and active fluidics, I think all of us know, so let's avoid. I'll skip directly into the panoptics. This is what has the slides I would like to reveal have been given by Alcon, and I'm presenting those slides. Definitely, all of us know the patient and economic burden of presbyopia. Sorry, what happened? Thank you. It's an age-related impairment. Whenever we look at vision, we look at three important things. Distant vision, of course, has to be very, very clear. Intermediate vision, with the advent of gadgets, as well as whatever is done in the kitchen and the routine work, we need this intermediate vision. Ideally, that should be at 60 centimeter. Please remember this number. Near vision, what we are taught traditionally at 33 centimeters, ideally is 40 centimeters, and this 40 centimeters is what is accepted by ANSI as well as AOA. Now remember these values: distance, infinity, that is 6 meters or beyond, 60 centimeters and 40 centimeters. An uncorrected presbyopic patient, of course, 10 years back I would have laughed at this slide, but then for the past 10 years, whatever I've undergone, I accept every point on this slide. It's difficult to see near without the glasses. It's also inability to read, particularly in the darker environments, impacts on the use of digital devices. We go around enlarging the fonts as well as increasing the illumination, requires the help of a friend. This is what initially, before starting wearing glasses, you used to ask anyone nearby to read this. You would have seen me struggle in the third screen in the morning because I forgot to bring my glasses. Now, what does traditional trifocals do? Now, the traditional trifocals, if they have to achieve this 40 centimeters, they have to place the intermediate focal point at 80 centimeters. Now, 80 centimeters is not ideal for an intermediate focal point. But this is the way it is. You place it, if you want your near at 40, it has to be at 80. This is what the traditional trifocals do. So instead, what they do is they try to reduce this near vision to 30 centimeters or 33 centimeters. Thereby, the intermediate point goes at 66. Carefully watch any trifocal lens that you get. This is how they have achieved it. But what has Alcon did differently, which they have patented, they have retained this ideal 40 centimeters. So if it is 40 centimeters, ideally the next thing should be at 80, but instead of that, they took 3 times and converted it into 120 and then gave half of that, that becomes 60 centimeters. So the intermediate vision came at 60 centimeters. Now the problem is there is a third point. So effectively this is a quadrifocal. But then if it becomes a quadrifocal, what happens? Light gets split into 4 instead of 3, and that becomes 25, 25, 25 and 25. So distant vision will suffer a little bit. To counteract that, what they did was the 4th point light, they changed it with their Enlighten optical technology. Now this is the patented part, and converted into distance. Effectively, what did this do? I have shown it in the latest slide. I'll talk about it. Added to this, of course, it's a hydrophobic, single piece, aspheric, non-oxidized, diffractive lens. Now the advantage here again is 4.5 millimeter of diffractive zone, 1.5 millimeter of refractive zone, 15 rings in this particular zone, and rest of the things is retained. Now changing this intermediate vision into distant vision, what did it give? Gave 50% of the light for distance. Retaining 25% for intermediate, 25% for near. So good near vision, small gadgets, good intermediate vision for computers, and good distant vision. What is the clinical data shows? I have removed a couple of slides which they are given in comparison. What I would like to talk about is this particular lens. They use this particular word, continuous range of vision. What does this mean? Between plus 0.5 till -3. That is a reading and plus on the other side. The vision is always 20 by 25 or 6 by 7.5 or beyond. Most of the times it's 6 by 6 except one small dip. The dip happens at 33 centimeters. If you use that as a logic, 33 centimeters, at least you get 6 by 7.5. Rest from 40 centimeters to distance, you get continuous range of vision. Gets excellent vision at -3, also at 0.6. When compared to a monofocal lens, the contrast is not reduced, almost similar. Contrast is almost similar, both in the scotopic and in the mesopic vision. And when this questionnaire was given to the patients to assess any severe visual disturbances, almost none of the patients reported any. 3.2% reported glare, halos 12.6 and 16% reported starburst. But remember, this is only in the early post-operative period. At the end of 6 months, 4.8%. That's what it is. Severe disturbances. Even these people got used to it. Very few patients had an explantation. No haze, no blur, no double vision, no dark areas. Dark areas was something in the hydrophobic thing, the negative dysphotopsias we were facing. 13 studies, 13 patients from 14 countries, 92% almost were satisfied with the Alcon Panoptix, Clarion Panoptix lenses. Of course, you have a toric variety also. This was another questionnaire where they were asked how satisfied were they with the vision. 95.3% said they were satisfied. 99% would undergo the implant again, and almost similar percentage would recommend it to others also. So they give deliver excellent outcomes. Clarion material and design, as usual, all of us know all the Alcon materials. This is the thing nowadays. Has less haze, exceptional stability considering the haptic. There was a beautiful comparison of multiple studies actually. This type of design gives excellent rotational stability, so the toric also is very good. And these are two slides in comparison. Axial shift as well as the torsional shift does not happen, happens less with a Clarion Panoptix trifocal lenses. Yes, the edge is modified a little bit to reduce that negative photopsia as well as PCO, and less than that percentage was what the PCO was. In summary, almost 92% of the patients who required spectacles were spectacle free after the cataract surgery, and almost 99% would get this patient with procedure repeated. Thank you, Alcon, for supporting this. We thank all the trade partners who had supported this particular conference. Now I get into my final talk of the day. I'll rush through this. We are already behind time, and there's one more talk in this session, again a trade talk. Of late, if you had looked at what was happening, please, my second talk. Yeah, thank you. Management ocular surface before and after cataract surgery. If you'd asked this question in 2000 when I was a postgraduate, or immediately when I started my practice, what is this? This is a disease that starts immediately after cataract surgery, lasts for 1 week at least, and then reduces. This is what we used to tell. Just add some lubricating drop if the patient complained of certain things. But then these two studies, if you look at it, opened our eyes. Happened around 2013 to 2017, wherein ASCRS, which is a surgical society, had to give norms for a medical problem. Between 2013 and 2017, that is the time, maybe 2008 to 2013 was the time when we started noticing dry eyes in cataract surgeries. So the surveys revealed that there is too much confusion. They were overwhelmed with the results, and they were unaware of the new tools and guidelines. Hence, this surgical society also asked, what do you want? They wanted an algorithmic treatment, meaning something which is idiot proof. Anyone can follow this and do it. Then came the concept of providing this algorithm. Any algorithm should be consensus, evidence-based, reduced chair time, can be incorporated into practice and classified as visually significant or not. Needless to talk about this slide, IOL calculation is affected, has poor post-op quality, and if you are unlucky in a dry eye patients, we end up with this kind of infections. So this particular talk I have classified into all these pre-operative, perioperative, post-operative, and what else we have to do. Pre-operatively, Please look at this. This is the algorithm that was proposed by ASCRS. Non-invasive surgery planning. It can be possibly repeated. Like I said, it's idiot proof. So even your receptionist or the optometrist can do this, and still it will be reliable. So before even the patient is taken up for any kind of workup, do this. Do the IOL measurements, do the pentacam or whatever other things you do. Why is that? We don't want the tear film to be affected. Also, while doing this procedure, you can assess the tear film also. That's how it is. Look at the Myers. Teach this to your optometrist to look at the Myers while looking at it. Any small differentiation on the anterior surface, also look at it. The next step, when the patient is waiting outside, give him a questionnaire. What did the ASCRS study say? They supported this modified speed 2 questionnaire. It was a modified speed 2 questionnaire. What I do in my practice is use an OSDI. Give this, ask them to fill so that you can quantitatively evaluate what are the symptoms for this patient. Then look at the patient. Now, 2 things they proposed. One is osmolarity, and number 2 is the inflammatory marker. Practically, this is not possible. You would have heard Dr. Rohit's talk in the screen 3. Maybe someday inflammatory marker surgeries would be possible, but practically doing an osmolarity, I am slightly away from it. Instead, what I do is look at the tear film height, and then even without a mabographer, you can still look at this meibomian glands with the help of your autorefractor. Then lift, pull and push the lid. Look at the lid for any changes, say meibomian glands, say blepharitis. Lift the lid again to see any other abnormality. Pull the lid to see whether there is laxity. Push the lid to see what are the secretions. Then you decide whether the person has OSD, ocular surface disorder. No OSD, directly go ahead with the surgery. If there is OSD, you have to see whether it is visually significant or not. How do you decide that? 2 things. One is a vision, or even your autorefractor or keratometry or your pentacam readings, which changes with every blink, or if there is any such kind of marks on the anterior surface. Second is the staining. So do different ways to find out whether it's visually significant or not. Visually significant, treat this patient and then take up the patient for surgery. Non-visually significant, directly go ahead with the surgery. This is the most important step that you have to follow. The rest of the slides I'll be rushing through right now. Intraoperatively, 2 things. We know there's a new technology that's being used, surgical temporary ocular discomfort syndrome. That's what is used for dry eye instead of calling it dry eye, some fancy name. But then if you look at all the mechanisms of dry eye by different surgeries, you would notice the cataract surgery, 4 different methods. That's the significance. That's probably because of damage to the nerves, all other things. So single most thing, if you have to take it, do not touch, do not injure anything what is not required. Example, conjunctiva. Don't push the conjunctiva. Very important. And then place your incisions properly. Use less drops. So this is what I do. Repeated drying irrigation. How do you mitigate this? Use viscoelastic on the cornea, on the entire ocular surface, cover it. Less eye drops. What is the dictum I follow here? 2 drops of povidone, 2 drops of anesthesia, no NSAIDs, and preferably without preservative. That we don't get. Avoid phototoxicity. Reduce the time taken for surgery. Do not touch any part of the conjunctiva. A point to be noted, flax is going to be the future, but remember, dry eye after flax is relatively more common after than when compared to a normal surgery. So avoid damage. Now what do you do in the post-operative regimen? I have a few studies. Again, I'll rush through this. Group A, B, C and D will directly go to what they found. Group D, using lubricating drops routinely with your antibiotic, steroid, NSAID and dilating drops provided much better safety. Patients were satisfied. Schirmer's T-BAT was reduced. Schirmer's was normal and T-BAT was also normal, and only problem was due to frequent usage of drops, patient was not very happy with the fourth thing. Cyclosporin only when there is proven visually significant dry eye preoperatively, use it. I'm not going into the studies. This is one thing I was in a period when we first started with dexamethasone, and immediately within 2 to 3 years we had shifted to prednisolone. Noticed all the dry eye after shifting to prednisolone. Probably there's some factor. That's what this study proves. Shifting back to dexamethasone would be better. Use less of NSAIDs. Very new index, ocular surface frailty index, not yet proven, but then what it says is anything takes 9 different factors and says anything in this above 0.33 is supposed to be significant. How they arrived at it, it's a long story, still not practically possible. What do you use in these patients? Again, look at the symptoms, try to diagnose dry eye properly, use the algorithms. Now the question comes, I'm a clinician, I don't have all these things in my clinic. Simple fluorescein strip, you can still diagnose and evaluate dry eye. That's what the Asia Pacific Dry Eye Society proved. Depending on the stain patterns, you can qualitatively and quantitatively assess the dry eye and accordingly use the treatment. As regards the treatment, commonest, of course, is the lubricating drops, but then dry eye disease syndrome, you know the amount of treatment that we use. So instead of getting into this particular aspect, let me directly concentrate on what is the lubricating drop that we use, otherwise that itself will be an entire day. Whenever we use any kind of medication, we should make sure that this is a multimodality acting medication. Then we can reduce the number of medicines that we give it to the patients. If you look at this particular thing, tear film stabilization, corneal epithelial bedding, osmoprotective activities, increased mucin secretion, reduced inflammation, which is the only thing that comes here. Of course, it is the last one, serum, which is something which comes very close to that. What is marked here? Hyaluronic acid, or a combination of CMC with trehalose if you can, but this combination right now is not available. In between it is available for some time. Hence, the choice of using a multimodality drug, I would like to prefer, if you look at all these things, HA, hyaluronic acid, CMC. Again, hyaluronic acid, CMC. Hyaluronic acid, CMC. But when it comes to agents reducing inflammation, is the higher molecular weight hyaluronic acid. That's the reason I prefer hyaluronic acid in patients with cataract with dry eye. I prefer hyaluronic acid. But remember, some patients can be allergic to this hyaluronic acid also. Thank you for the opportunity. I call upon Dr. Anandraj Nagesh to come and present us. We'll have the discussions later.
No, other one. Nagesh A. Generation levels, they offer a great spectacle independence, offer excellent range for distance, intermediate and near vision, and minimal or tolerable dysphotopsia. There is a lot of noise about these EDOF lenses nowadays. Every company is manufacturing, every company is coming out with EDOF, a true EDOF, or a modified EDOF, or enhanced monofocal, whatever you say. They lack near vision. They offer only the intermediate vision. But presbyopia correcting level should have both intermediate and near vision, good near vision. So we can guarantee this N6 only with this trifocal eye holes. So this slide shows it all. You can see all other lenses do fail in giving a good vision at 40 centimeters, except this. Of course, this slide, the visual simulator is from the Alcon. You can see that there's the only one which gives at 40 centimeters. Even EDOF fails there. We'll know all how this works. Basically, it's a diffractive type of multifocal eye hole, and the step heights are modified to create a 3 focus. And this is the patented triphobic technology of IOCare lenses. They have this decreasing step heights, and also the angulation is increasing from center to the periphery, so that the glare and halos are very much minimized, and their ad is near ad is for 3.5 and intermediate as 1.8. These are the properties of the eye hole. There's a glistening free material. It has got 12 rings. That's where it scores about the Alcon and diffractive optized technology. It's a patented step profile technology, and spherical aberration is 0. It's a pupil independent lens and manufactured by synchronous cost molded, so that there's no polishing involved, and with the dynamic energy transfer, 50% of energy is distributed for distance, 30% for near, and 10% for the intermittent. Only less than 10% will go away, which can cause some noise. That's why the glare and halos are very minimal. Prerequisites, we all know: a good optical biometry, a healthy ocular surface, no comorbidity, and an OCT macula should always be done wherever possible. And with all the available lenses and with all the gadgets, we still hesitate to put. Why? Because we think that we may end up in some refractive surprises. So, when you have optical biometry, definitely you can promise a very good result. And glare and halos, as I said, it's very minimal and reduced contrast sensitivity. Of course, theoretically it is possible, and practically it's also proved. But how many patients will come and tell you their vision is low in the radius lens? Nobody, actually nobody. So this is the defocus curve from the triophobic. It is as similar to other lenses. You can have 3 peaks here, one for distance, intermediate and near, as good as other lenses in the market, like the Synergy, Panoptic, CT-LIS and all. And just rush through all these things because of lack of time. The contrast sensitivity and visual acuity is all good with the toric or non-toric as well, compared to the extended depth of focus. This again contrast sensitivity showing here, and the sine wave contrast sensitivity test again. A little with higher special frequency, the EDOF lens slightly scores better in mesopic and photopic conditions, but otherwise it is trifocals are as good as EDOF lenses. And this is a meta-analysis showing the near vision. The trifocal levels always have an edge over the extended depth of focus. So where are we now? When we started using multifocals, we were carefully selecting patients whom to include. Now we have come to a stage where we offer these lenses to almost everybody, and we now only exclude the patients. So, and how many of us involve this in the counseling? We should always involve it. Offer the trifocal technology to all the potential patients, and explain the benefits rather than any features of the lens. And also, this hook line use for most of the patients is a once in a lifetime surgery, so they will accept this and go ahead. And a few of my own cases, of course, we learned a very good refractive outcome in the normal eyes, but a few of these examples which are showing moderate myopia, the axial length is 26 here in the right and 20 and 27 in the left eye. The level chosen was 14.5 and 11.5. Look at the refractive, it's 0, both for distance and near. Patient had very good vision. Other moderate myopia patient where the IOL power was 13, and in the right eye I had used a toric lens. Again, the distance correction is only about 0.25, and other eye is of course showing 0.5, which is there in the pre-op as well. So it gives a very good outcome. Other one with hyperopic eye with 21 axial length, and the IOL use was plus 28, and the right eye it was toric IOL. Again, the patient had very good vision for distance and near vision. Of course, I do check myself many intermediate vision. We don't have an option to include here, that's why our MRD doesn't capture there, but we do check, and patients do very well with intermediate vision as well. Another simple toric IOL, I'll just finish in a few seconds. Here it was 1.6, 1.7 in the right and left eye. Both eye had 22.5 with the toric IOL, and patient had landed extremely well. And there's a small video showing its excellent rotational stability and centration. Even though I do hydro implant the lenses, I do go behind the IOL and wash off whatever little visco is adherent to the lens when we are loading the lens, and then center it, and then align it to the axis which is marked there. So the only two reasons where we does not consider is when the surgeon is hesitant and an uninformed patient. So confidently go ahead and inform the patient, and you will end up with very good results. Thank you.
Thank you, sir.
Thank you.
That was a very good talk on lipobicaol. Seem to have 2 more minutes. Are there any questions for any of the speakers? This is the end of the session. So I would like to thank all the speakers for spending their valuable time in the busy schedule to be here and give us all their talks on the cataract. So we would like to call all the speakers for a photo